So assalamu alaikum to all of you. A very warm welcome to each and every participant. Good evening, good day, good afternoon, good morning, wherever you are joining us from different parts of the world. We are back again with the Health in You Community Wellness Series, and we have a great expert speaker lined up today for you all. So just as a reminder, if you all don't know me, if you all have not attended our sessions, I'm Dr. Suhaila Chima. I'm the Assistant Dean for the Institute for Population Health and an Associate Professor of Clinical Population Health Sciences. So very warm welcome to you all from the Institute for Population Health and from Weill Cornell Medicine in Qatar. So just to remind everybody about what Health and You is and why we are doing this series. So it's really to create community awareness about health and disease. And we really want to enhance self-care, reduce suffering in the community, improve the quality of life, and increase healthy longevity. So just as a reminder, some housekeeping. Your cameras and microphones are turned off. Please use the Q&A feature to type questions or comments. You can also put your comments in the chat. We will be able to see them. Questions will be addressed at the end of the session. I will be moderating the session. This is not a CME CPD activity, as a reminder, and no certificates of attendance will be issued. So this is what the topic is today, which is depression. So again, these are some of the topics that we choose for the wellness series. Are basically, these topics are suggested by the community to us, and then we reach out to experts, on those topics and bring them back to the community. So the topic is our depression, and the session will really provide an overview of the impact of depression on health, what the symptoms of this disease are, its complications, and the need for treatment. So we have an excellent speaker. I'm really, really excited to have Dr. Aicha Hind Rifai with us. And she is our Assistant Professor of Clinical Psychiatry at Weill Cornell Medicine in Qatar. She is American board certified in psychiatry, in internal medicine, and geriatric psychiatry. She's also a consultant in women and perinatal health at Sidra Medicine, and she is also a consultant at Hamad Medical Corporation. She's also the director of the psychiatry clerkship at Weill Cornell Medicine in Qatar. So Dr. Rifai, a very warm welcome to you, and over to you now.
Thank you very much, Dr. Chima, and good evening and welcome everyone. Thank you for having me. I'm happy to be able to speak about a topic that is of great importance in general and specifically to our area of the world where we always need to know more about mental health issues so that we prevent them, we act quickly so that we seek treatment for the patients who are affected, and we also participate in the education of the general public. I prepared a general presentation because the topic of depression is literally huge. There's a lot to say about it, and this is just a very small introduction. May I have the next slide, please? So I have no financial relationships to disclose and will not be discussing any unlabeled, unapproved use of drugs or products. Next, please. These are the learning objectives of this session. First, to highlight the significance of the problem, define depression, talk a little bit about the causes of depression, the course of the disease, its complications and outcomes, and an introduction to management. Next, please. So, how significant is the problem of depression? It's actually one of the most significant medical issues in the world at the moment, and it is a leading cause of disability worldwide. Basically, a lot of people are affected, and it contributes to poor health and a global burden of disease worldwide. The World Health Organization in 2021 put out these numbers, was estimating the prevalence, meaning at any point in time, what is the status of disease in the world, how many people are affected. And it estimated it to be at 5% of the world population. So if we say that the world population is 7.5 billion people, at any point in time, 350 million have depression. Now, these are 2021 statistics and not 2022. And that the significance is that the number have increased significantly after the pandemic, and we will expect greater numbers coming up at the end of this year. Next, please. Who gets depression? There are general notions that certain people get depression. Maybe someone who had a problem, a personal problem, maybe somebody has a medical problem. The truth is that I highlighted here which groups get depression. More and more, we are finding out that children and adolescents have depression, can have depression. In adulthood, women tend to have more than men depression. Pregnant women during the pregnancy and after delivery have depression, are at high risk for depression, and we'll talk about that. And old age is a significant risk. As people age, their risk for depression increases. So looking at this, everybody is at risk if they have certain vulnerabilities, if they have causes, and we'll talk about that. Next, please. There are many types of depression, and I just put a few for us to have an understanding of how we classify them in psychiatry. Next, please. So we talk about one depressive episode, meaning one time having depression, or recurrent episodes, meaning several times having an episode of depression. And I'll be talking about what is a depressive episode consists of. So some people have one and never have another again, and some have several over their lifetime. There is depression in people who have bipolar disorder, or what used to be called manic depressive illness, and that's a different type of depression. There is what's called the peripartum and postpartum depression, which is related to pregnancy. Peripartum means at any point during pregnancy, from the beginning of pregnancy, and postpartum is after delivery. We have what's called psychotic depression, where patients not only have symptoms of depression, but also have symptoms of psychosis, like hearing voices, having false beliefs, being afraid that somebody is after them. This is a very dangerous type of depression, which I'll allude to later on. Then we have a persistent depressive disorder, which is a lifetime low mood, which can start in late adolescence, and people can function, but are never 100%. They have many weeks every year where they suffer from depression without ever being sick enough to be severely hospitalized, but their quality of life is impaired, and those need to be taken seriously. Again, many of you must have heard of seasonal affective disorder. We're lucky here not to really have much of it, because we are in a country where there's sun all year round, but this is a major reason for depression in countries where there is low sun months. Starting in October, September, October until April, you see a pattern of depression year after year, which impairs life basically for a significant number of individuals. So those are the types of depression. And there are some more we don't need to get into. Next slide, please. So I'm going to ask you a question, and this is our first poll. If you don't mind, Raji. Which of the following is a symptom of depression? Please, you can check as many as you like. As you see, low mood, sadness, irritability, loss of interest or loss of pleasure, weight loss or weight gain, too little sleep, too much sleep, good concentration. Okay, well, I think we can stop the poll. It looks good. I'm glad nobody checked good concentration. And we will talk a little bit more about the symptoms of depression. So as we see, we'll go to the next slide and we'll finish the poll.
You can
This
just,
is what,
you can
excuse
just move the poll box away if it bothers you.
okay. So we have, as you see, many people have checked low mood. Some have checked irritability. Loss of interest has been checked, weight loss or weight gain. And too little sleep or too much sleep have been checked, and no one checked good concentration. So there's a good knowledge among the audience about really depression. And can we close it now? Okay. This is what the symptoms of a depressive disease are. DSM-5, you may have heard of the DSM-5, which is the classification of mental diseases, is the reference for psychiatry in defining disorders. And number 5 means the fifth time it came up. Every time from DSM-1 to DSM-5, every few years, this is updated so that it reflects the stand of knowledge that we have currently. And DSM-5 came out in 2013, and this is what we use. So in order to say that someone has a depressive disorder or depressive episode, as we said before, they have to report consistently to have experienced over the past 2 weeks 5 of the following. So the 2 weeks, the consistently, and the number 5. So depressed or irritable mood is important. And some, especially in children and adolescents, we see less depression, we see more irritability. And that can be also in adults. We see loss of interest, loss of pleasure in almost all activities, what's called anhedonia. People stop liking what they used to like. They don't want to bother with activities that they used to love to do. And this is consistent. There's significant weight change and appetite disturbance. Sometimes there is, you can see weight gain, and sometimes you see weight loss. Sleep disturbance, poor sleep, or hypersomnia, which is increased sleep. Psychomotor agitation or retardation means people are either are totally sitting in one corner, which is retardation, not moving, and even when they move, they are slow, they walk slowly, all their movements are slowed down, or they are restless, pacing, agitated, going up and down, not finding any type of peace. Fatigue or loss of energy, people don't want to get up from bed. They feel tired, they are exhausted, having slept, even the ones who have slept all night and slept 12, 13 hours still continue feeling fatigued. feelings of worthlessness. The patient inside, this is an inner, so everything else we have talked about was an outside symptom that we can look at, a sign, what we would call sign, but the patient themselves, inside of them, feel worthless, guilty. And what we notice is that they can't think or concentrate and can't make decisions, what they frequently refer to as brain fog. They feel foggy. They have recurrent thoughts of death. Sometimes they just think about this. Sometimes they think about killing themselves. And we'll talk about that further on. Next slide, please. There are additional symptoms that is important for everybody to know. The psychotic depression, where patients hear voices, that's what's called hallucination or delusions. They have false beliefs. Either they think somebody is after them, wants to hurt them, or they think in depression that they have done something terrible, that they are somewhat guilty. And you cannot, this type of thinking, you cannot just tell them, oh, no, you didn't do it. Or they think, for example, that they have an incurable illness. It's not the type of belief that you can just wash away and say, forget it. You know, you didn't do it, or you don't have an illness. It's a firm, fixed, false belief. The hallucinations and the delusions are very dangerous because they put the patient in a very troublesome reality. They believe things that are not true. They can be very scared, and they have an increased suicide risk. Catatonia is a part of psychotic depression, and that's where patients absolutely cannot get up from bed. They are nearly unresponsive. They are awake but unresponsive, and we see that in severe depression. In the setting of bipolar disorder or manic depressive illness, we will know that the patient has, when they present with depression, we will ask whether they had mania, mood elevation in the past, which will clarify the picture for us. Next, please. Peripartum depression. I want to talk about this because this is a hugely important topic, and there are lots of misconceptions about it. Many people think that pregnant women are happy women, but the truth is that it doesn't work like that. Next slide, please. At their highest risk, if you think of a woman throughout her life, if we're not talking about loss or trauma or major life events, if everything else is going fine, her highest risk for depression is during pregnancy and after delivery. That's the highest time when she's likely to have depression. Worldwide, 1 out of 7 women have depression during pregnancy. We're talking every place, we're talking the statistics coming from every area of the world. So it's not a disease of the Western world, it's not a disease of a certain culture. And then we have the postpartum depression, and that's up to 18 months after delivery is postpartum. The postpartum depression, I think there's a lot more awareness about it in the last few years, and the primary healthcare centers have been doing a great job in doing assessment of patients who had recently had a baby and assessing them for depression and referring them for treatment. So we have a lot more awareness here. It can start within 24 hours of delivery or several months after. And it can be severe with psychotic features, as we talked about. And suicide is the leading cause of death of women in the postpartum phase. In that phase, in the first year and a half of a woman delivering, suicide is the highest reason for them to kill themselves because of depression. The other issue, of course, is that they're not able to attach to the baby that they just had, as we saw in the picture. They are unavailable emotionally, and the impact on the baby is very big. What I wanted to say is that there is a misconception now, because many people have learned about baby blues. We started seeing patients who have really depression, whose families are saying you have baby blues. And baby blues are much milder form of lower mood, of sadness, sometimes crying, that doesn't last. It's a few days, up to 1 to 2 weeks, and then goes away. It's not the depression that we are describing, as I described in a depressive episode, with not being able to sleep, with being irritable, with depressed and restless, agitated, not knowing what to do, not being interested in anything or the baby. So we have to be very careful, because it seems like now the people are talking a lot about baby blues, and sometimes letting patients with full-blown depression, families with full-blown depression, young women who are not getting treatment. After a couple of weeks, there is no baby blues. It's depression until proven otherwise. Next, please. So, poll 2, let's look at that. What are some of the causes of depression? Check all that applies. Okay, I'm going to end the poll. Very good. And as we see here, all of these are causes for depression: job stress, relation problems, moving to a new country, medical problems, pregnancy, all can be causes of depression. We can stop the poll and move to the next. Next, please. So there are different causes for depression, as you all highlighted. However, all of these causes have one common pathway, which is they lead to a biology disturbance. And the biology disturbance is what shows itself as signs and symptoms of depression. There are genetic forms of depression, families that have depression, and that's something that we ask always our patients who present with depression. If there's anyone else in the family that has it, frequently it is. Medical illness, medications, some medications that patients are taking. Substance abuse is a cause of depression, hormonal changes, loss and trauma, life events, divorce, the death of a loved one, bereavement after a long marriage, losing one's partner. Next, please. So this is the list of the medication that can induce depression. It's not they're not all well known, how significant in the sense of their causing depression, but they all need our awareness. So when a patient presents being on one of these medications and has depression, we need to keep in mind that they could be due to the medication, that the depression could be due to the medication. Of these, I would like to highlight some of the anti-hypersensitive medications because they are very common. And also the corticosteroids, the steroids that patient may be taking. Oral contraceptives are a leading cause of depression, and smoking cessation agents like Chantix. Chantix came on the market and people thought, okay, great, it's going to stop people from smoking. It did, but it caused a lot of depression. So we need to be always evaluating our patients for the medication that they may be taking, which can be contributing to the depression. There are other medications as well. I mean, interferons, if you have a patient who's having treatment of cancer, they're going to be having at least 30 to 40% chance or risk of having depression. Let's go to the next slide, please. And here are the most common medical illnesses, and I think it's generally well known that the first thing that we do is when we have a patient who has depression, we check their thyroid, that it's not under functioning. We check their vitamin B12. Women who have not entered menopause completely but have started in the menopause stage, what's called perimenopausal state, when the periods start becoming irregular, when hot flashes are increased. This is the high risk for depression. Once a woman enters menopause, then the situation calms down. The hormonal disturbances tend to taper off, and that situation resolves. And neurological disorders, we know that dementia can have depression as well as Parkinson's disease accompanying them. Now we have long COVID-19, and long COVID-19 is a new disorder that has multiple problems following a COVID infections. What is sad about it is that the majority of the long problems or the long-standing problems are actually neurological and psychiatric. So a lot of depression, a lot of weakness, a lot of fatigue, a lot of fogginess, and of course, more serious neurological disorders. But if a patient had COVID-19 and is having depression, it's worth trying to put the two together. Next, please. Let's look at the poll 3, please. What are some complications of depression? Why, besides being an awful disease, what can happen to patients with depression? Okay, we can stop the poll and share the results, and we see that all of these problems can happen to patients who have depression. They have medical problems, relationship problems, divorce, alcohol or other drug abuse, death, employment problems. So we'll talk a little bit about that. Next slide, please. So what are the complications? Suicide is the most dangerous complication, and I have a slide on that specifically. We see worsening of medical illness. You see worsening of diabetes, cardiovascular disease, whether it's heart disease, whether it's hypertension, worsening of chronic pain syndromes, stroke, worsening of stroke, in the sense of patients don't recover as well after a stroke if they have depression. So what I'm saying of worsening of medical illness, the patient who has diabetes and has depression has a worse diabetes. Patient who has diabetes, who has a myocardial infarction and has depression has more complication and has a poor outcome. Same with stroke. And stroke frequently has depression along with it. So patients who have a stroke and depression are slower to get better and may have more deficits in the long run. They're not able to participate in rehabilitation. And even beyond that, their disease is significantly, their stroke is significantly worse, and their weakness. Substance abuse, patients start feeling terrible with depression, and they do what's called self-medication. They start either, if alcohol is available, they drink alcohol to feel better. If some friend has something that they took from some friends or on the street or from a doctor, they'll self-medicate with these medications that are being offered. This is a serious problem. Of course, depression is very hard on the couple. It's very hard on members of the family. It leads to relationship disruptions, divorce, and at the end, homelessness and unemployment. Next, please. So what? Depression is the leading cause of suicide in the world. Patients don't, and this is a long discussion that has been ongoing for years and lots of studies on it. Patients who don't have depression don't commit suicide. It is a biology that makes people attached to life no matter how many problems they have. Once they become depressed, their attachment to life weakens and they can actually kill themselves. Although we see more suicide attempts in women lifelong, the men are the ones who finally kill themselves more often, completely. So that's what's called completed suicide, the difference between attempted suicide and completed suicide. The patients who really should worry us are the patients who are expressing hopelessness. When a patient starts feeling hopeless, talks about feeling there is no hope, there is no future, there is nothing I'm looking forward to. These are the patients who are at risk for suicide when they have depression. The interesting thing is that some patients have depression, never have hopelessness, and never attempt suicide. But the patients who have depression and have hopelessness are the ones who frequently will attempt suicide. So we are human beings need to have some hope to continue going on. And when we lose hope, then we can't go on. And that's what we see with patients. That's where it's really dangerous. So we divide the phases of suicidality into a phase of what's called passive death wish, when a patient just wishes they would die. I wish I wouldn't wake up tomorrow. That I wish, I have a car accident and something happens to me and I die. Then they start having suicidal ideation. And meaning they think about, how would it be if I killed myself? And then they start having an intent to kill themselves. They want to kill themselves. And then they start thinking about a plan to kill themselves. So in the evaluation of a patient with depression, we evaluate all of these phases to see where the patient is. And of course, once the patient start having suicidal ideation, it's extremely dangerous because that can go very fast. In psychotic depression, and I do talk a lot about psychotic depression because not enough people know about it, sometimes people will kill themselves because their voices that they are hearing are telling them to kill themselves, or they are afraid because they feel somebody is after them and they're going to hurt them. So they do something to kill themselves. So they are not really planning it, but it is a result of their beliefs. Next, please. So let's take poll 4, please. What are your ideas for the management of depression? What should we do when we have a patient with depression? Okay, great. Can you see, because it says stop sharing, can you see the results?
Yes, yes.
Okay, so a small percentage thinks that time will take care of this, and a good percentage thinks patient with exercise, lifestyle management can get better. Medication, psychotherapy are also options with a good number of people, and hospitalization, a small percentage. I think the best way of looking at this, next slide please, is by dividing the types of depression that we have. First of all, let's look at general rules. The treatment and the management is going to depend on the safety of the patient, on our assessment of risk for this patient, on their ability to take care of themselves. Am I looking at a patient who's not able to get up from bed and fatigued and not eating? Or am I looking at someone still up and, you know, trying hard and taking care of things, but struggling? And the severity of the disease. How impaired are they by the disease? Those are general rules for how we're going to think about the treatment. So always safety first. The general rule is involve family members. Always, whenever you have the opportunity, either family members or friends or collateral people who are there. It's, if you're not going to hospitalize a patient, you're going to need to try to get people to help out. And always start with ruling out medical causes that we have talked about by doing some baseline labs. Next, please. So if you have mild to moderate depression, patients are able to participate in these activities, patients are still somewhat functional. You look at lifestyle interventions, including exercise, you encourage activity, you increase the social support, and that's a tremendously important function. There have been studies showing that for people who are isolated and depressed, increasing social support over several months can significantly improve the mood. And social support means someone coming over, someone helping out, let's say with shopping, someone helping out with things at home. That's very important. And what we call cognitive behavioral psychotherapy, which in the case of depression is very, very, very effective. It increases patients' activity. It assesses their thoughts of guilt and feelings of worthlessness and addresses them. So cognitive behavioral therapy really originated in the beginning for depression. But these are patients who are able to come to you to the office, be referred, participate in exercise, open the door to someone who's going to come and help them. And I would say this is about 60 to 70% of the patients that come to a primary care physician with depression. Next slide, please. So severe depression, patients who is having the 5 out of the 9 elements of depression that we've talked about, who's impaired, who's not sleeping, who's agitated. This is a patient where you're going to consider hospitalization to make sure they are safe, and they are eating, they're not getting sicker. Suicide precautions are important. If you don't hospitalize the patient and decide to send them home with family, which happens unfortunately sometimes because the families do not want to have the patient hospitalized, prefer to take them home, you're going to check and see if there are guns, if there is access to a huge number of medication that the patient may take in an overdose. You're going to think about the safety of the patient now at home. Antidepressant medications, and I think the majority now of the population knows about medication. I'm not going into them. And the medications for depression are the SSRIs and NSRIs, and now we have the ketamine. And as far as the medication, not ketamine, they are most likely to be prescribed by non-psychiatrists. Primary care physicians do a great job prescribing medication, and that can be done in the primary healthcare system or in the private system. Psychotherapy needs a referral to a psychotherapist who's trained. Electroconvulsive therapy, what's called shock treatment, which has a really bad reputation, unfortunately, thanks to some really bad movies, is one of the most effective and safest treatments that we can have for patients who are severely depressed. You don't need to wait for the medication to work. It's very safe in pregnancy, and it's very safe in older people. Transmagnetic stimulation is a newer way of treatment, and it's not as effective as electroconvulsive therapy. It is a milder form of treatment, but it's also available. Next. Take-home message. Depression is a disease. Treatment is available and successful. And stigma against the disease can prevent treatment. And that's a big issue for us all, to participate in what's called destigmatization of depression, of understanding that it's a disease and seeking treatment ourselves for our loved ones so that we don't allow suffering to go on, and so that we prevent death sometimes. And that's it. Thank you. And I'm happy to respond to any questions.
Great. So thank you, Dr. Rifai, for that wonderful session. I think people can certainly take away, some key messages today from you. So let me start with this first question. You alluded to on one slide that children and adolescents, can also suffer from depression. where people might think differently, that this is only a disease of the adults. So how can you tell if children are depressed? I mean, I know, children can be considered up until maybe age 18, but is there anything specific or different in children that you see? And what is like the youngest age, that you can sort of say that, okay, this child is depressed? What is the youngest age that you can make that diagnosis?
There is no cutoff. The more we know about the biology of depression, the more we see that there are children who are as young as 7, 8 years old who have depression. Now, the difference is between having a low mood, not feeling good for a few days, and having the full-blown description that I gave of a major depressive episode. When a child is irritable consistently for many days, not functioning, not eating, not sleeping, not interacting with other children, it's worth an evaluation. It depends on the causes. Sometimes there are causes that are transient, if, for example, there are family issues, but it is worth an evaluation. So
Sure.
as far as all age group, the definition of depression is the same for all age groups, and we don't have cutoffs.
Sure. Thank you, Dr. Rifai. So just to talk a little bit more about that, do you see any specific causes in children, which may lead to depression? Can you talk a little bit about those?
Well, so I will say that one of the major issues is bullying in school and difficulties. So depending on the phase of life that the children are going through, the phase where children are in school, it's very important to see their interactions with the people around them, and those are the other children. Other reasons are very important, which are happening at home. Children can be abused physically, verbally, and can become depressed. And that's a very important consideration. So those are the two things that I would think of first. Sometimes the family is going through difficult times. A parent dies, other things which are much more, people understand right away. You don't have to explain that to them. While bullying and abuse need a little bit more attention because the child is not going to be speaking about them very quickly, and you'll need to investigate that.
Great. So we have an excellent question. Of course, we talk a lot about depression, and of course, we know, I mean, I was really shocked to look at the numbers, really, and especially when you said that during pregnancy, 1 in 7 women. So I was really actually shocked to hear that number, because I certainly wasn't aware. So what would you say if somebody came and said to you, okay, what is it that I can do to help myself? So is there a way maybe to prevent depression? Or how can we do self-help, to sort of maybe not, move along that pathway? Okay, if, of course, we're all humans, we get depressed, sometimes things go down, but how do we sort of, what can we do? Or what are those strategies that we can do which will help us stay on the right path and not go towards, depression?
I think it's a very important question. There are multiple sociological changes that have happened over centuries that have made people more disconnected. So I think social coherence, social support, closeness to family members is very important in maintaining good quality of life. People have been living more disconnected. There are a lot more conflicts in families. There aren't enough opportunities to be together. So I would say social cohesion is very important. On the personal level, I encourage people to be active. The lifestyle of being at home, watching TV, being on the mobile, the digital lifestyle is not a healthy lifestyle. It might seem to be, everybody knows that, but the truth is that it causes depression. Right. And an active lifestyle. So people who get up in the morning and take a walk around the block, if they are healthy enough to be able to walk,
yes,
are doing something for their mental health. There are so exercise, activity, socialization are a huge ways of preventing depression. As far as women who are at risk for in pregnancy, during pregnancy, besides the fact that it is really a hormonal state that makes women vulnerable, what we know is that the quality of the relationship between the woman and her husband is the key issue in her depression. There are women who have depression regardless of how good things are, but a good number of patients come because of significant problems, either in the marriage or with the in-laws in our societies. So there's a lot of friction, there's a lot of pressure, there are marital issues or in-laws issues. And those need to be also, people need to be aware of them.
Yes, I think, thank you so much for that answer. These are very, very real problems that exist in our societies and all different societies. And I think we all need to make a collective effort, in trying to sort of address these. Okay, so we have more questions. So some related to, so there's one question asking, does depression affect blood pressure? So I'm thinking, they're asking, maybe they're hypertensive, does it increase your blood pressure, or does it normally, even if you're not hypertensive or you don't have high, but will it affect your blood pressure?
Yes, depression can elevate your blood pressure. And if you have hypertension or high blood pressure, it can cause your medication not to work as well. So you're taking your medication, you go to the doctor, you have high blood pressure, you're given medication. Unfortunately, you get depression, the medication don't work as well. The state of depression in the body is not only in the mind, it's all the body is sick when you have depression. So besides having no ability to, the medication don't work as well as all the stress hormones that usually raise your blood pressure, the steroid hormones that are in our body to help us when we have a stressful situation, when we are afraid, they pump into us so that we get out of a difficult situation. In depression, they lose control. We are always under stress. Our level of steroid hormone is so high that on the one hand, we're taking pills to bring down our blood pressure, and on the other hand, our depression is raising our blood pressure. So it's a very important question for sure.
Great, thank you. And like you said, it's a disease of the whole body. So I think that's so important for people to understand that our mind and our bodies are all connected. So of course, if there's something which is affecting our mind, it does affect all our body also. So another question, which is, I think, again, like, what people have in their minds. So it's about antidepressants. And are antidepressants responsible for suicide? Can it lead to suicide?
So this question has been on the mind of many people. Big studies have happened. Of course, there's a big concern about this issue. The largest studies that have been published have shown that no, there is no correlation between suicidality and medications, especially in the adult. There is no correlation. And as a matter of fact, the risk of having suicide if you don't treat depression is much, much higher. So this has been studied in larger than hundreds of thousands of patients, this correlation. When we look at children and adolescents, the concern has been somewhat raised, somewhat unresolved completely. And that's to be perfectly honest. And I'm not a child psychiatrist. I think this question, as far as I am aware, is still on the mind of people, and it's worth discussing if someone takes their child to the doctor and the doctor wants to prescribe the medication. It's worth listening to what the data is saying. For me, it's a daily update, because in terms of what depression and medication, so I update myself in the age group that I treat all the time. And it's the same for children. So I wouldn't say yes or no. I would say, listen to your doctor, ask the doctor. Certainly the risk for illness is very high if you don't take the medication.
Mm-hmm. Great, thank you. So we have another question. So she talks about, she says mental health in the Middle East is not accepted as a disease, as you said so eloquently yourself. The question is, how do we normalize it as a disease? But I think it's not only the Middle East. We see it in many different parts, that it's basically, people don't want to talk about it as a disease. People will talk easily about, oh, I have diabetes, or I have a heart problem. Nobody talks to you, oh, I have depression. So I think it's not only a problem here. What would you say to that, Dr. Rifai? How can we start normalizing it? How can we start accepting it, reducing that stigma that is attached to it?
So now here we are, our group. This is an effort as destigmatization. Education, every person who is sitting, listening, reading, every person who has had depression and had treatment for it should be talking to other people about how well they are doing. Stigma is part of the medical history. There was stigma at some point from tuberculosis. They wouldn't even mention the word tuberculosis. It was referred to in the Middle East as that other disease, not even saying the disease. Next, cancer became an illness. So, mental illness has always been stigmatized because there's the idea that either you are weak or you're not religious enough, that if you prayed and you read Quran, you would be good, or you read your book, your religious book, you will not have depression. So the fact that you have these symptoms means that you're not religious enough, or you're crazy. And craziness, unfortunately, is some term that seems to come from the Middle Ages that carries towards psychiatry. Psychiatrists treat crazy people. So unfortunately, no, we don't treat crazy people. We treat the most sane people, as a matter of fact, and people in great distress. So the World Health Organization has put mental health actions around the world right now. It's called mental health gap, interventions, multiple work, multiple initiatives. But we also, on a daily basis, need to correct other people, need to inform them, need to normalize the discourse, talk with each other.
No, absolutely. And I think it starts right from each of us. And how we think about it, and how we, spread knowledge about it, and talk easily about it. So I think we have another fantastic question. I know we're at 6, but there are great questions. So if you don't mind, I'm going to just ask you some of those. So again, like we know, just dealing with your loved one or a friend who's going through depression can be very stressful to people around you, your family members, people who care about you, or if there's a carer, maybe looking after an older person. So what advice would you give to the carer? What can they do in sort of dealing with this? Because sometimes it can get very overwhelming for the person who's looking after a depressed individual.
Burnout is the biggest fear for patients' families, for families who are taking care of people with depression, and especially if it's one person. We know that. We see it at some point. You don't know if the patient is the sick one or the person who's taking care of them. So it's acknowledged, it's extremely difficult. My advice is to try to see if you can get help from other people. Not one person should be taking care of the situation. First of all, have the person be in treatment. The longer this goes on, treatment can work very quickly. In a couple of months, patients get better and the situation gets better. So first, get appropriate treatment. And I know it's not easy. Sometimes, you know, the patient themselves don't want to come. Families don't want to bring, oh, well, I don't want you to take my brother to the psychiatrist, things like that. But anyway, in primary healthcare center, this is the blessing. You're not going as a psychiatrist. You're going to a regular doctor who will be able to help you. Second thing is you have to take turns. One person cannot be taking this burden on their own. And acknowledging that this is very difficult and I need help is the first step. You should not be ashamed, whoever it is, we should not be ashamed to say, this is too much for me. I need help. So these are, and see if you can get help. Sometimes the person needs to be in the hospital. The person who has depression needs to be hospitalized. They should not be taken care of at home by one single person. And I know it's difficult for some families, but it's an option sometimes.
Yes, yeah, it's a difficult situation, but like you said, these are some of the strategies that you can try and see and try and, you know, work to an optimum. So just as a continuation of that same question, Dr. Rifai, how can family members, you know, help alleviate a member who's suffering from depression? So of course, you know, depending on the different kinds of treatment that person gets, what can they do maybe in the social environment, the family environment, you know, which can help, you know, alleviate the suffering that depression maybe is causing for that individual?
So when a patient has severe depression, actually they have a hard time having people come around to be social. And actually, you know, you hear loving grandmothers say, I mean, I loved my grandchildren coming home and being around me. Now I can't stand the noise. I want them to take them out. So it depends on the situation, on the severity of the situation. Sometimes the patient needs peace, rest, understanding, encouraging, what we call behavioral activation, encouraging, for example, getting up, not staying in bed, encouraging, let's try to take a walk, making sure that they're getting nutrition. I always, you know, say to family members, when patient doesn't want to eat, try ice cream, try something with high nourishment, with high caloric value. Small steps until the medication starts working. So I wouldn't say socialization may be good for some people at some stage, but it's not at every stage. And also I would ask the patient, I'll take the cues from the patient. Do you feel like doing this? Should we take a little bit of a walk around? So balancing what you think is a good, healthy lifestyle and what the patient wants. One thing I would encourage is as soon as possible, get them out of bed and get them dressed, and not, you know, get them dressed. And if it's a woman, you know, have some appropriate clothes so that they don't, you know, enter into a vicious cycle. If a man tried to shave him, things like that.
Okay. Sure. So that sounds good. Just, you know, like daily things which we would do on a regular basis, you know, just trying to sort of, okay, let's get fresh, change, shower, you know, so that's also they're simple things, but they can certainly help them. So again, I think one question sort of also relates to that about Of course, like you said, there are many different levels of depression. Could be mild, moderate, and severe. And I really, of course, there are many studies also now on that, and you share that in your slide also, that mild to moderate depression, can be treated with lifestyle interventions and exercise. So I think that that's such a fantastic thing by itself, where people might, if they have mild to, just by doing lifestyle, and you don't need to go towards drug treatments and pharmacological agents. So these can really just help you address if you have mild to moderate depression. So how receptive do you think, if you have depressed people in your families or in your as your friends, how do you think, like, if a person is talking to them, how should we sort of say, just to boost their morale, how easy is it for them to understand that, okay, you have a problem, let's try and address this problem? What are your thoughts about that? How can we sort of encourage them, to take that first step towards recovery?
Well, it does depend on on people, how they approach things. But I believe in action rather than conversations in those situations. The best studies show that having a buddy, a friend, either to socialize with or to exercise with, that's called, they did it actually on a study in London, in the city of London, in women, middle-aged women in their 50s who were depressed. They called it the befriending study. They assigned women friends who would come and visit them and go shopping with them, or go exercising, doing something with them, go do some activity. And within 6 months, the depression symptomatology was significantly improved without medication. Mm-hmm. So from this study itself, it shows that we don't need to be talking constantly about depression with these people. We need to be just doing some pleasant things. So it may be in the beginning that you just sit down and make sure that you're, in a pleasant environment, that the room is fresh, that the person is clean. Then you start going out a little bit, doing a little bit of activities.
Right.
So that's what I mean. Without talking all the time about depression, it could be easier. Just do. You will have it in your own mind that you're doing the healthy activities for depression, but it wouldn't be always a subject of conversation. It's easier.
Sure. Yeah, great, absolutely. So just the last two questions. So how would you differentiate sadness from depression? People feel sad, and how do we sort of say, okay, is there sadness, or is there, I know you've gone through a slide, on where we sort of say, okay, this would mean, but maybe you can just reiterate that, please.
So sadness, patients know how to differentiate that. What in English, when you ask a patient, how do you feel blue? Do you feel down in the dumps? Depression is a constant feeling. It does not change. It doesn't come and go. A patient who has depression will not be laughing for, watching TV in the evening, laughing with the family, and then getting in low mood the next day. That is not depression. That's a stage. Of course, they can have psychological distress and other issues, but a patient with depression is unable to change their mood like that, even when there are pleasurable stimuli. It's a profound feeling, not only of sadness, but also of being disconnected from the sense of pleasure, from the taste of life. And that's what we're talking about in depression.
Right. So I know that you'd mentioned the word hopelessness, also, which is closely related to depression. So
some people have hopelessness with depression, some don't. But the general feeling of depression is beyond sadness, is beyond any feeling, is a deep, dark place where people are unable to feel any joy, any pleasure, any interest in what's around them.
Right.
They feel sometimes irritable. They act, they become difficult to deal with. It's
Yes.
because they don't feel well. While
Great.
sadness has a transient part about it, meaning it comes and it can go and it can be affected by pleasurable experiences, or it can be changed by whatever happens. It comes and goes.
Great, thank you. Just one last question. So again, on antidepressants, so do antidepressants lose their efficacy when consumed over long periods of time?
No, actually, once a patient responds to antidepressants, and we call response is by resolution of all symptoms. At that point, we say that the episode is finished. After the episode is finished, we continue the medication for 6 months. Let's say I see a patient when they came, they're on a scale of 1 to 10, 10 being their best mood, their mood was 2. They had 2. And when I get with the patient with the medication to 10 and they're at baseline, the day they are at baseline, we count 6 months. And then we start thinking about cutting down the medication because one episode is finished. Now, some people who have recurrent episodes need to stay on medication, need to be on medication, maybe the full dose or cut down the dose. Medication do not lose their efficacy, on the contrary. And sometimes we notice that patient may decide to stop the medication on their own before they're ready and not discuss the issue with their doctor. And then they come back and they have full-blown depression. So the strategy of treatment of depression is very well known, is very well studied. It's not like whenever. And no medication that are working well don't lose their effect.
Okay. Okay, great. So I think we are already 15 minutes past 6, but it's been an excellent session. I think very informative. So we would really like to thank you, Dr. Rifai, for giving your time. So it's been wonderful having you, and I'm sure our participants have also benefited from their session. And
thank you all.
Yeah.
Thank you all for the good questions and
yes.
For the good.
Yeah, I think we had excellent questions. And again, these are very real questions, what people see around them, or maybe even they have basically, problems happening, or they see in their families or in their loved ones, and all of that. But thank you again so much for your time and for your expertise that you've provided today. Everybody is thanking you for the wonderful session also.
Of course, please go out and spread the word all against depression. And good luck, and hope to see you in the future. Take care. Absolutely. And thank you, Dr. Chima and Raji and all the team. See you soon.
So I would also like to thank all our participants, so we do these sessions for you all, and the sessions would not be anything if you all are not attending. So really grateful to have all our participants joining us from different parts of the world.